So tonight I would like to introduce the next in our Ungerleider lecture series. For those of you who have not been here before, this lecture series is sponsored by Doctors Stephen and Shoshana Ungerleider, who have made an endowment in order to promote palliative care education here at CPMC. And as part of that endowment, we are having a series of state-of-the-art lectures for our staff and community. And tonight, it is a real treat to introduce Eric Widera. Eric is an associate professor of clinical medicine at UCSF. He is the director of the Hospice and Palliative Care Service at the San Francisco VA and also the director of the UCSF Geriatrics Fellowship Training Program. Eric went to undergrad at UC Irvine and then medical school at UC San Francisco before heading to the other coast to do his residency training in internal medicine at Mount Sinai. He subsequently came back to UCSF to do his geriatric training before joining the faculty at UCSF and the VA. Eric's CV is 17 pages long, and it is littered with just a range of prestigious honors and awards. He has numerous teaching awards from UCSF and their associated training sites. Eric has received an American Association of Hospice and Palliative Medicine Soros Foundation Project on Death in America Palliative Medicine National Leadership Award, as well as being named one of the AAHPM's Hospice and Palliative Medicine leaders under 40 years of age. Are you still under 40 years of age?
Squeaked in by a couple.
Okay. So kind of a ringer. I think for those of us that are attentive to the popular press, Eric is also very, very well known. He is the co-founder of the palliative care and geriatric blog site, GeriPal, as well as the co-founder of the website ePrognosis that was featured with a front page article in the New York Times. And I think in your first week of that website being up, you got about 500,000 hits on that website. So it continues to be a resource that I use regularly. So with no further ado, Eric Widera speaking about prognostication.
So I'm kind of a wanderer. Can everybody hear me okay with this? Perfect. Over there, Davies, can you hear me? Perfect. They're waving. So thank you for the introduction, and thank you for coming today. Today, I'm going to talk a little bit about prognostication and really focus on a couple components of prognosis. The first is determining kind of why prognosis matters and what role it plays in healthcare right now. The second is determine some ways we can estimate prognosis. And lastly, just talk about a couple ways that we can communicate prognosis with our patients when we are talking to them about it. I'm going to start off, just a quick poll. How many people here actually practice specialty level palliative care? That means you're involved with hospice care, that you're running or part of a palliative care consult team, inpatient, outpatient. Raise your hand if you are. Okay. So that means the vast majority aren't. But even for those who are doing this, what I'm going to try to focus on a little bit is there are a couple of core tenets and principles in palliative care, including prognosis, and the importance prognosis plays in everything that we do when we're communicating with patients. And a lot of what we've focused on in kind of our work in palliative care is how do you take these principles that were just part of medicine 100 years ago, or even 50 years ago, like prognosis, and how do you build it into the architecture of what we do in a healthcare system, no matter where you are, independent on whether or not you do palliative care as a specialty. More importantly, actually, is if you're providing primary care to patients or you're doing hospitalist care to patients, how do you build this into the architecture of daily life just like this tree is built into the architecture of daily life. And that's a little bit about what we're going to be talking about today. And we're going to do this through a couple different ways, but first we're going to start off with a case. And this is not a normal palliative care case, but this is very much based on the core principles of palliative care, including the importance of prognosis. So this is Mrs. A. She's a 68-year-old clinic patient with heart failure, COPD, dependence on others for shopping, household chores, has difficulty walking a quarter mile. She's been hospitalized once for her COPD. Should you recommend that Mrs. A have colon cancer screening? I'm going to ask you to do a closed eye vote. So we have GI colleagues here too. Everybody close your eyes. I'm not going to tell you anything more about the case. Even if you want to know more about the case, you can't get that information. Should we recommend to Mrs. A that she get colon cancer screening? Everybody, close your eyes. Everybody who would recommend it, raise your hand. Everybody who wouldn't recommend it, raise your hand. May lower your hands. Close to 50-50, probably around what, 40, 60. Most people, the majority, wouldn't recommend it. And we're going to be talking a little bit about kind of the role prognosis plays in these decisions, as well as other decisions, and the important part that prognostication plays. So again, before we go into that even, let's actually just define what prognosis is and what prognostication is. So I think one way to think about it is you go to somebody who has a crystal ball, a fortune teller. Fortune teller, what is the first thing a fortune teller does? Takes your money. A lot of analogies with healthcare, but sits down, has the crystal ball in front of her, and looks at the crystal ball. So she's foreseeing, or he's foreseeing the future. Second thing that they need to do is foretell the future. So if they just stopped at that, it wouldn't be a very good fortune teller. They'd actually have to communicate to you what the prognosis is or what the future has in store for you. So that's kind of one analogy. Another analogy, and I think weather matters a lot. Weather matters a lot as far as when we're thinking about prognosis, because we're all used to this. So if I'm going to ask everybody in this room right now, Davies too, will it rain on Wednesday? So what are the steps that we need to do for you to answer that question to me? So anybody, will it rain on Wednesday? No. I'm getting a definitive yes, no, and that was a no. And how are you making that decision?
Why don't we define what rain is? People what happened today, rain.
Yeah, big meta. I actually just tweeted that because I wasn't sure, is this fog or is this rain? It's like a metaphysical question. But let's maybe, will you have to turn on your windshield wipers? So I think there's a couple of things that actually need to happen. Is the first thing that you need to do is you yourself have to estimate a prognosis of the likelihood that this event is going to happen. You can use things like apps or websites that can help you. So this is weather.com. Weather.com has both a yes, no, will it rain? And you see a little rain cloud on Wednesday. And you also see here a more probabilistic approach. There's a 50% chance that it's going to rain. We'll get back to actually what we mean by 50%. But that's the other important part, is you can tell me there's a 50% chance it's going to rain, so communicating that prognosis to me. But the third important step, which is often forgotten when we're talking about prognosis, is that I'm going to actually interpret what you just told me. So you may tell me it's not going to rain, and I may just leave the room and say, okay, he says it's not going to rain, but you know what? I looked at weather.com, and it says it's going to rain, so I'm going to ignore your advice. I'm still going to bring the umbrella. And I think that matters, and that analogy fits really well into how we should think about prognosis in the healthcare setting. So let's move on. We're going to remember these three steps. We're going to go back to these three steps. So first is estimating the probability. Second is communicating the prognosis. And third is interpreting that prognosis. So why bother with all of this? Why bother with these three steps? Why is this important? All of our decisions have some estimate of the likelihood, the needs. Are we going to need the big bag or the little bag of paper towels? In healthcare, these decisions are often magnified. So, for instance, in healthcare, talking about prognosis provides some realistic or some idea of what are some realistic achievable goals. It also helps us determine whether the likelihood of an intervention will be consistent with these goals. So, how many of you heard this line before? If your heart stops, do you want electrical shocks and chest compressions to try to get your heart beating again? What's wrong with this line? Yes?
Hey, we may not get your heart beating again. Yeah.
So we may not. So there's nothing about the likelihood of an outcome that is consistent with their goals. I hear this line all the time. There is no prognostic information in this. There's nothing about the context of their illness, nothing about whether or not it's going to achieve the goals that hopefully you've already identified. And it matters. This is a study going back to 1994, which is very old in academic terms, but actually not very long ago. And what this study did is they asked a bunch of older adults about end-of-life preferences. 44% initially said, yeah, I would want CPR, because why not? But when just given one additional statement of the likelihood to survival to hospital discharge, number dropped in half. It was just one additional prognostic statement. They didn't ask about goals. They didn't frame everything the way we were taught how to frame things around CPR. Just adding something about prognosis changed dramatically how people make decisions. So prognosis matters in that regard. Prognosis matters for eligibility. And I think most often we think about hospice. What's the hospice eligibility guideline? 6 months. Anything else recently come up as 6 months? In the news? On Governor Brown's desk? Assisted suicide, death with dignity, physician-assisted death, whatever you want to call it. We're going to have to estimate prognosis if that bill is signed as far as a life expectancy of less than 6 months. So there's eligibility reasons why we should be fairly good at prognostication, both delivering that information and estimating it. It matters for people with other reasons outside of our traditional healthcare system. This is an article that we wrote on advanced financial planning for patients with dementia. And I can tell you, most of the time when I make a diagnosis of dementia, I'm thinking healthcare decisions. We got to make decisions because we know what to expect. They will not be able to make decisions for themselves in the future, maybe a couple years from now, unless they die of something else first. We know what the future has in store. We have a crystal ball. How much are we preparing them to help with healthcare decisions and other decisions that matter a lot, like their finances? Who is going to make their rent checks when they can't anymore if they're living alone? Are we preparing them for that? Other reasons prognosis matters? Because people want to know. This is a study from Alex Smith looking at older patients, 65 years and older, diverse background, African American, Chinese, Latino, disabled San Franciscans. 2/3 want to know their 5-year prognosis, and 3/4 want to know their 1-year prognosis. So this is important. I think it's important for 2 reasons. Most people want to know what their prognosis is. And these are very often disabled individuals, but not everybody. And this is the really important part about asking or inviting people to have these discussions. Because there are some people who don't want to have that discussion. And the last thing I'm going to talk about is, and going back to the case of Mrs. A around colon cancer screening, what we want to do with our interventions is target to those people who are most likely to benefit, who are less likely to be harmed, and who are going to live long enough to see the benefit. And this is the idea, a concept of lag time to benefit. For a lot of our preventative interventions, there is a lag time to see any benefit from them, but they're exposed to the immediate harms of the potential intervention. So for instance, something I see frequently in my work in hospice and palliative medicine even in our hospice unit, where median survival is about 21 days, is intensive diabetic control, intensive glucose control. How long does it take to benefit from intensive glucose or sugar control? 7 years. So if you actually look at some of the data, so comes from the UK PDS trial, looking at microvascular complications, which come before macrovascular complications like stroke. So this is stuff like nephropathy, retinopathy. You're looking around 9 years till these two lines separate. So 9 years till you see a meaningful difference between the group that got tight glucose control versus not tight glucose control. So about a decade. So for our patients who come into our hospice unit, median survival 21 days, should we be doing tight glucose control? No. It offers them no benefit. What are they exposed to? All the harms. Falls, hypoglycemia, and especially those people who may have not weeks, but maybe months or years. There's even some association with worsening cognitive status. Again, exposed to all the harms. What about Mrs. A, colon cancer screening? How long does it take to see a benefit from colon cancer screening? And it's shocking. If you actually look at the literature around people with advanced cancers, how often we still do screening tests on them, like colon cancer screening. I see some nods. How long does it benefit from colon cancer screening? 10 years. So this is a study from Say Lee looking at colon cancer screening. You see, it takes 10 years for us to prevent one colorectal cancer death per 1,000 people screened. So you got to screen 1,000 people to prevent one colon cancer death at 10 years. So you don't want to target these people. You want to target these people who are going to live long enough to actually see the benefit. And there's a whole host of these decisions. I'm frequently focused on decisions that are shorter, like should I start an SSRI, antidepressant, on somebody who I think may have weeks to live? Are they going to live long enough to see the benefit from the SSRI, which may take 8 to 12 weeks? Or are they just going to expose to all the harms, and should I try something else like psychotherapy, methylphenidate, or something else that may work shorter? High blood pressure control and diabetes. Much more reasonable. Much shorter lag time to benefit than tight glucose control. Something that we may want to do for people who may have years, but not decades left to live. And again, this is part of the bringing in the bedrock of what we do in palliative care prognosis into the daily architecture of healthcare. And how many of you, statins? The amount of times that I see people come into our hospice unit, again, median survival 21 days on a statin, which takes 6 months, a year to see any true benefit. It's amazing. We see all these medications. I got to tell you, the amazing thing sometimes that I see in our hospice unit is sometimes we just take away a lot of medicines, and it's amazing how better people look sometimes when you just prioritize the medicines that are most important to them. So, 3 parts of prognostication. Talked a little bit about why this is important. Let's talk a little bit about how actually to do it. So we're going to focus on estimating prognosis. So I like to think about it first kind of as, yeah, this is really tough. Anybody know who this is? Now, everybody thinks it's Yogi Berra. Everybody thinks this quote originates from him. It's actually Niels Bohr, theoretical physicist. And he said it's exceedingly difficult to make predictions, particularly about the future. And I would add, particularly about older adults. Younger adults often have one illness, one terminal or advanced illness that may actually significantly impact their prognosis. Older adults, we're dealing with cognitive issues, we're dealing with functional issues, we're dealing with multimorbidity, so they may have more than one medical problem, and we're also dealing with age. And all of those are important factors when we're thinking about prognosis. So trying to put this all together becomes that much more difficult versus a younger individual with an advanced cancer once we start seeing that functional decline in the cancer, it's a very bad prognosis. And this is kind of the focus of a lot of our work, which is around aging and prognosis. So I'm going to talk about 3 particular ways for the older adult we can think about estimating prognosis. The very first way is clinical judgment. How good are we at estimating prognosis as healthcare providers? Good. Nobody here said terrible. Because I got to tell you, I've given this talk multiple times, and the first thing I often hear is terrible. We are not terrible. Our estimates actually correlate with actual survival. So we're good. We're just biased. How are we biased? When we think about our clinical judgment, when we're estimating prognosis, we tend to be a very optimistic group. So if you look at study after study, we overestimate survival by a factor of about 3 to 5. We're an optimistic group when we formulate a prognosis on top of actual survival. Unfortunately, when you actually look at actual survival in this solid line, and then this next dot, I don't have it, this next dotted line right here is formulated survival, so how I'm thinking in my brain how long someone has to live. We're more optimistic. And then when we actually communicate that with our patients, we're even more optimistic. So on top of our formulation, when we actually discuss this with patients, we're optimistic. So it's optimism on top of optimism. And we'll talk about another aspect is when patients hear it, they're more optimistic on top of what we've communicated. So it's optimism on top of optimism on top of optimism. So to sum up, we actually, our estimates do correlate with survival. They just tend to be biased towards optimism. Furthermore, the longer we know someone, the worse our prognostic estimate becomes. Again, probably adding because of the biases that we have. And we're actually much better at very short-term prognosis than longer-term prognosis. So some of the issues that we have. But clinical judgment, still incredibly important. Second thing is life tables. So another thing we can look at is age. So if you look at past colon cancer screening guidelines, there's an age cutoff. Greater than 75, stop. Or really do it between ages up to 75. So how good is age? And we can look at life tables for that. So again, going back to Mrs. A, 68-year-old, multiple medical problems. On average, how long does a 68-year-old have to live? Another 20 years to age 85, I heard. Somewhere around there. So if you actually look at life tables, this is in 2007. It's a little bit longer now. You can see on average, if you've made it to 68, median life expectancy is another 17.5 years. Less than 20, probably closer to 18 now in the last decade, but not too far off. So for her, just based on age, should you recommend colon cancer screening? Absolutely, right? Just based on age, she's going to live longer than 10 years. And this is the problem with age, is that there's a lot of heterogeneity in how people live. If you actually just break it up, this is another one of our colleagues, Louise Walter, who just broke it up in the top 25th percentile, bottom 25th percentile, and median percentile. You can see that there's over a decade of difference for 70-year-olds between the bottom 25th and the top 25th, let alone the bottom 10th and the top 90th. It would be widely different. And that means that there's a huge heterogeneity. You can have 70-year-olds who have the same prognosis as 80-year-olds. And again, the hard part, though, is figuring out who's in the top quartile, who's in the bottom quartile. How do you know this? Again, going back to some of the key tenets in palliative care is function matters. And this is true for geriatrics, too, is a lot of what we focus on is function, because function helps us determine prognosis, even for longer-term prognosis. So this is another study out of UCLA looking at, same thing, it's a life table, so similar as before, but what they did is they have age here and then just functional status here. Are they independent? Do they have one ADL disability and mobility? Or are they ADL disabled? And you can see that you can have an 85-year-old who has the same life expectancy as a 75-year-old, depending on just their functional status. You can also throw in other things like comorbidities, like Mrs. A. Do they have CHF? Do they have end-stage renal disease? Do they have dementia? How bad is the dementia? Do they have severe COPD? Do they have cancer? And how do you combine all these together? And this is really where the third way to estimate prognosis is prognostic indices. And this is, especially for our older adults with multimorbidity, is they're not going to be in a cancer study because generally those are very healthy older adults who are enrolled with it without a lot of other medical problems. So we need a way, instead of just pulling out a study, to figure out kind of what is their prognosis. So what's a prognostic indice? It's really something that we use all the time in medicine. Chad's 2 score, Framingham score, any nurses in the room? Yeah? Braden scale, Morse-Falls scale, all prognostic indices help us determine what's the likelihood of a specific event happening over a set period of time. And it could include issues from our history, or it could include factors from our history, our physical exam, or any lab findings. And the reason that they're important is that they lend credence to our own diagnostic judgments as far as prognosis. Most of us, how many of you have ever been trained in prognosis and prognostication? Priscilla, she did fellowship with us. And if you ask majority of physicians, they've had not a lot of training in this. This is an art that died many years ago. It used to be kind of what we didn't have a lot of treatments. We just focused on diagnosis and prognosis. Now we have a whole bunch of treatments, and prognosis has been kind of pushed to the wayside. So it's about bringing it back into decision making. And the goal here is we're supposed to help combining these clinical estimates from prognostic indices with our own clinical judgment may actually result in better estimates of prognosis. So what we said about, this is several years back, is to actually look what's written out there in the literature. We did a systematic review looking at prognostic indices for older adults that are not disease specific. Because, again, for most of our older adults, it's not a specific disease what we're concerned about. It's the manifestation of all their different comorbidities, their age, their cognition, their function. And we identified 16 validated non-disease specific prognostic indices, and we evaluated their accuracy and generalizability. And what we found is that there were some of these that were actually accurate, developed and tested in large diverse settings, and actually well validated. We recommended cautious use of them and really combining those indices with our clinical judgment. So we were super happy because this was a medical student who was with us. So she was first author, and this was published in JAMA. So what can we do with this? Well, for this lady, 68-year-old CHF, COPD, dependence on others, for shopping, household chores, hospitalized once for COPD, you can actually pull up the article, look at these different indices, see what their development cohort and validation cohort is, look at discrimination, calibration. You can find out, maybe the Schoenberg index is the right one for you to be looking at. You can then pull up the citation. At UCSF, we'd have to VPN first to get the article because it's not a free article. Then we'd have to go to PubMed, pull up that article, finally read the article, come up with this, which comes from the article, tally up the points. But there should be an easy button. Because none of us are going to do this, honestly. And I think that's the one thing in academic medicine is usually we would say, yay, we got our paper accepted, and move on to our next project. But how do we actually decrease the barriers for these things to actually be used? Because they're not used often, these indices, because they're lost in the ether of PubMed. So what we decided to do is put them all together on a website. So we created ePrognosis, which is a website where you can say where the patient is, what time frame that your bets fits your clinical issue, and some other questions. And it takes you to the index that we think is most appropriate for both the setting that the patient's in and some of these other basic questions. So for instance, this one takes us to the Lee-Schoenberg index. You put in some answers to questions, and it tells you, like for this patient, out of 100 community-dwelling adults age 50 and older with similar answers, 87 will die and 13 will survive over the next 10 years. Graphical representation, we decided actually not to actually mix it up a little bit so people don't think, because inevitably people will think, oh, I'm the person who's not going to die. But honestly, we don't know who is who based on this. So if you saw this, 87 out of 100 will die, or 13 out of 100 will survive, should Mrs. A have colon cancer screening? There may be some preference-sensitive decisions. So this is one of those things you actually may want to talk to Mrs. A about. She may be very anxious because her sister and her brother both got colon cancer, and she's worried that she's going to get colon cancer. And in that case, she may say, you know what? I hear this, but it's still something that would relieve my anxiety. And you may decide, okay, let's do it. It also may be that based on this, she's going to be exposed to a likelihood of some harm, but very low likelihood of benefit, and she may not want to do it. Question?
Well, my question, Rick, is about the likelihood of harm.
Yeah.
That it'd be one thing if you're exposing her to a fit test, and it's
Yeah.
another thing if you're giving her a colonoscopy,
Yeah.
because part of this prognosis shouldn't be not only are you going to live long enough, but how much risk is this particular patient having in terms of whatever the intervention is.
So
Yeah.
we're going to get to that in a second. Because, again, we didn't just stop here. But I just want to throw this out for the palliative care colleagues out there. There's several indices on there. So if you actually put in hospital and then click whether or not they have a palliative care consultation, we also have the palliative performance scale on here too. So for those who are actually doing consults, you actually can pull up the PPS, which has been tested mainly in patients in hospice, and there's one of these for hospice, and in the inpatient palliative care consult setting. And you can put in this information, and you get a worst, best case scenario, and most likely scenario as far as their prognosis. So for you palliative care colleagues out there, check it out. But we also created an app, and it's also on a website now, so you can actually get it on your phone. But for Mrs. A, you can actually say, what would you like to screen for? Is it colon cancer, breast cancer, or both cancers? This is for older adults. You answer similar questions. And it tells you, based on harm to benefit, using basically something coming out of a car, where do they fall in? Is it going to most likely harm this patient, or is it most likely going to benefit them? And you can click on some other buttons like Learn More. And you can see that if you put in these questions, out of 1,000 people like this person who got tested for colon cancer, 100 will experience a harm in the first year. One person will avoid death from colon cancer, and 700 will die no matter if they got colon cancer screening or not. And then you can also click Harms and Benefits, and it tells you a little bit, what are the actual harms and benefits? Now, I think the personalization of this, there's no app that's going to really personalize it to the person in front of you. And it's very hard. I think that's one of the difficulties with prognosis. We can kind of come up with an estimate, but actually determine exactly, for certain, whether or not, just like whether or not it's going to rain on Wednesday, you will never be certain whether or not it's going to rain on Wednesday. The weather is too complicated. And it's just like humans and prognosis. It's too complicated for some prognoses. So, going back to Mrs. A, 68-year-old, should you recommend that she have colon cancer screening? After listening to all of this, I just want you to think about it for a second. I won't do another polled vote. But there are some other great prognostic indices out there that you can actually get online. So, for instance, there's the Seattle Heart Failure Model, which comes as an app through Hippocrates. So you can actually, for disease-specific indices, and there's a whole bunch of these out there, you can actually put in information that tells you 1, 2, and 5-year prognosis and how that's affected if you do other interventions. There's an inpatient heart failure mortality prognostic index, which tells you their risk at 1 year and their risk at 30 days. Nephrology in the room. There's one for dialysis patients, Cohen's prognostic model. And it asks this really important question. Would I be surprised if the patient died in the next year? And that question is actually a very important question when it comes to prognosis. Why? Because our clinical judgment actually matters. Yeah, again, all of these, I can send my slides out, but you can get all of these online. So we talked a little bit about our 3 ways that we can estimate prognosis. We can use our judgment. Good. We can use age, life tables. Okay, but it tends to wash out when you include other factors like functional status, like comorbidities, like cognition. Combining all of them together, probably the best thing we can do to estimate prognosis. So I'm going to pause for a second. Questions about number 1 so far? Because we're going to move on to 2 and 3 in a second. Yeah.
It looks like this is just for colon cancer screening or prognosis, or not colon cancer screening.
So the app, and we also have a cancer screening e-prognosis website, which is specific for breast and colon cancer screening at this point. And then we also have the main e-prognosis website, which you just put this information in, it brings you to the index, and is not specific to any type of preventative intervention. It's based on these prognostic indices. What's the likelihood that someone will either live or die in a specific time period? Yeah.
We recently had a visiting professor. I apologize, I can't remember his name. We recently had a visiting professor who's a surgeon, and I suspect you didn't know his name. Johansson, working on a frailty index for surgical patients, not specifically to assign prognosis, but rather to assess a more granular piece, which is their ability to undergo a specific surgical procedure, assessing risk and benefit, and not only to help with the decision-making about going forward with the procedure, but equally were there mitigating steps that could be taken if you identified someone had a high frailty score.
Yeah.
And somewhat to my surprise, our surgeons are extremely interested in this. And it just strikes me that they're doing this on a more granular procedure-based level than a more broad level, as you've just described. And I don't know if you're familiar with that, or
Yes.
Yeah, I suspected you might be.
And I think, a lot of the frailty stuff is the things that some of these prognostic factors look like. Not everything like grip strength, but weight, function. And I think this is the hard thing with current electronic medical records. We are terrible in documenting function. Vital signs, pulse, blood pressure, whether or not somebody can do their ADLs or IDLs, we are absolutely horrendous at documenting. But that's actually an incredibly important factor as far as determining prognosis and the trajectory of that. So I think we're slowly moving forward, but we got a lot of work to do.
The surgeon are embracing it. Must be getting
Yeah.
I was just going to ask a question, maybe a setup question
Yeah.
for you, that might feed a little bit into the next items that you're going to be discussing. But in the news, we're constantly reading about all of these breakthrough treatments. Yeah. And I'm just hoping you could reflect on how your e-prognosis instruments are going to change as a result of all of these reports that we're getting about the next new cancer treatment for the fourth-line chemotherapy or targeted molecular therapies.
I think the great thing is, like, for instance, metastatic lung, non-small cell lung cancer, some of the treatments have really kind of revolutionized kind of prognosis. Not cure, not extending people's lives often by decades, but by the order of 6 months, a year even with some of these. So we're seeing that. We're also seeing, if you just look at life tables, that we talked about, let's go all the way back. So this is data from 2007. I think we've gotten about a half a year more just in the last decade based on life expectancy. A lot of that was things that happened decades ago rather than things that are happening now. Some of our treatments we haven't really seen, while they're often talked as revolutionary, significantly improving people's life, and especially like if you look at cancer trials, most of them, the revolutionary treatments for advanced cancers were maybe extending prognosis by weeks, maybe a couple months. And when we're looking at older adults with multimorbidity, there's no multimorbidity pill. There's no age pill. Treatments to slow down dementia can currently be counted on no hands. So a lot of the illnesses that we see on our older adults, we have not even come close to figuring out how to change that. And oftentimes the things that really matter to people are not those interventions that may give people another couple weeks or months. It's those interventions that are going to help the caregivers, help keep people independent at home. It's the non-pharmacological treatments. And again, that's what we see with like dementia. Maybe one more question, we'll move on.
I wanted to ask you about, does your prognostication include the quality of life and how much that's going to diminish along with not just life and death, but how people are going to fare and how their lifestyle is going to be?
Yeah, so importantly, a lot of my talk so far has been focused on mortality predictions. And there's a lot of predictions outside of mortality that matters. So like the CPR study, when we talked about the thing that changed people, it was a mortality prediction. But it's really not the thing that matters most to people when they're thinking about decisions like CPR. It's, will I be in a nursing home after I am discharged from the hospital? Will I be able to think? Will I be able to talk? What's my function going to look like? That's what matters to many people. Some people, it's just along my life no matter what, but most people, it's all of those things. So when we're thinking about prognosis, it's thinking more than just mortality. Currently, our site is focused on mortality. In probably the next 6 months, we'll have some stuff around other things, like institutionalization. But that's a great question. So let's actually move on. We'll have more time for some Q&A. Let's talk a little bit about these two, communicating prognosis and interpretation prognosis, in the last about 10 minutes. So this is probably something a lot of people have seen. This is a very kind of key communication skill that pretty much all our kind of fellows nowadays are talked about. It's getting more and more into medical school training. Simple ask, tell, ask. When you're delivering communication or prognosis to somebody, ask them. Ask them what their understanding of what the future may have in store for them. Invite them to have this conversation. Invite them, do you want to talk about kind of what the future has in store? Because remember, most people want to talk about it. Most patients think that you're the one that's supposed to bring it up, so they won't. And the other is, there are some people who don't want to talk about it. So instead of forcing it down on them, maybe talk about why. And if they really still don't want to talk about it, back off. Eventually, you will actually get much farther than if you try to push this upon people. So ask them. Ask them about how much they know, what their perspective of their prognosis is. Tell them. Give information. Short, bite-sized, non-jargony. Also focus on that this is sometimes, often, a very emotionally hard thing to do, both for yourself and for the patient. So focus on emotions. And then ask. Check for understanding. 3 very simple things that I try to remind myself to do. Sometimes I forget, and I still have to remind myself afterwards, okay, I forgot to actually start off with the patient or the family member. Because I'm so used to busy, 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 tell them, move on. And I got to remind myself, inevitably it goes bad because I haven't started off with this. So I'm going to focus now a little bit on tell. And I think this is one that doesn't get a lot of press in the prognostic literature, but starting to be talked about more, is a little bit about certainty. Anybody know what this was? Yeah. Priscilla. Yeah, what is this?
Hawaii.
This is Hawaii.
I don't know the names, but there was recently like 3 different hurricanes brewing around, and
Kilo's over there.
no,
I was
over that. He was on that side.
No,
Yeah.
Kilo. That was the hurricane name.
Oh, okay.
That one.
Yeah.
But the 3 hurricanes, beautifully captured in this. This is a picture of their wind speeds. But you can see, and Hawaii is right over here. I was actually in Hawaii when this picture was taken. So knowing something about prognosis became really important for me. Like, I'm planning to go take a trip to Hana while these hurricanes are coming. Where are they going to go? So you can actually look at it. This is a picture of Kilo, the track of Hurricane Kilo. This is where the hurricane is or was, and this is the track of the hurricane. Now there's something funny in this picture. There's this white stuff here. Anybody know what this thing is called? Uncertainty. The cone of uncertainty. This means that, honestly, we only know for certain where the hurricane is right now. We've really advanced in the last 50 years in figuring exactly where the hurricane is, but we've also figured out over the next 5 days, we're going to a lot better to figure out where the hurricane is going to go through modeling, basically like prognostic indices. But there's uncertainty. So you could just have the track, but it gives people the false impression that we're fairly certain where this hurricane's going. This is 70% of the time it's going to fall within these two lines. So we have some certainty where it's going to be here, a little less here, and as we go out, it becomes more and more uncertain where this hurricane is going to track. And it's the same thing when we think about healthcare and certainty. So for instance, if we're thinking about prognosis, I am actually very confident, nearly certain, that everybody in this room will die at some point in the next 100-ish years. Like, I have a fair amount. Anybody else want to disagree with that? Outside of like us transferring our intelligence to a computer system, our bodies will die. Like, there's a high level of certainty there. What's going to happen over the, and I'm assuming everybody here is rather healthy, what's going to happen over the next coming decades, less certain, but I'm pretty sure, highly certain, that you're probably going to live that long. And I'm also fairly certain that everybody's going to make it out of this room alive after my talk. So I have differing levels of certainty. And it's the same thing when we're thinking about the ICU. We have, or any other place, we have various levels of certainty. For Mrs. A, we may have certainty what the next 20 years will look like. Fairly maybe uncertain what the next couple years will look like. But more certainty what the next couple weeks will look like. Same thing with the ICU. We may be uncertain whether or not this patient will actually make it to Saturday. We may be more certain that this patient may not make it out of the hospital. And we may have a high degree of confidence or certainty that the patient, if they do make it out, will end up in a nursing home and will have a poor level of function. So our level of certainty changes. So I think the key when we're talking about prognosis is bring in our level of certainty. How likely do we think something will happen? And how certain are we that it will happen? So for instance, in the nursing home setting, median survival is about 3 years. But there's heterogeneity. For some of our patients, we're fairly certain it's going to be shorter than that. And for other patients, they look really good, and we're fairly certain they're going to be in the middle, and sometimes we'll just have some uncertainty. So giving some people some ranges. So ways that we can do this is say that, while I'm unsure how things are going to go over the next couple days, I'm fairly certain, even with everything that we're doing in the ICU, your loved one will not make it out of here, out of this hospital alive. When we're talking about CPR, levels of certainty. So again, key point here when we're communicating prognosis is talk about that. One way we often do it in palliative care is ranges. They may have hours to days left to live, days to weeks, weeks to months. That gives a sense of certainty. And also relieves some of the pressure on us. Like, nobody expects that we have a crystal ball that's going to exactly define when someone's going to die. But I can tell you, people get really angry when the doctor refuses to tell them the prognosis. They realize we don't know for sure. And we'll get into some of that next. And that's the interpretation. So even when we communicate information, things get a little bit more complex. So, will it rain on Wednesday? We talked about this question. One answer was deterministic, yes, no, it will. What was it again, no or yes?
Before I saw your app.
Before you saw the 50%, right? What does a 50% chance of rain mean to you? Anybody want to answer that? If I say there's a 50% chance of rain on Wednesday, what does it mean to you?
There's a good chance it might not rain.
What's a good chance?
50%.
50%. Yeah.
Bring an umbrella no matter what.
Bring an umbrella. So the really interesting point there with the interpretation is, I'm going to prepare. It may or may not rain, but at least I'm going to be prepared if it does. And I think if there's one key point from this talk is the importance of prognostication. It allows people to prepare. That ICU patient that you may be uncertain how they're going to do, it gives the family prepared. Get that daughter from New York into that ICU. Or to let them know that you can organize all the flights you want. We don't think he's going to survive that long. One more. Anybody else? What does 50% mean to you?
Don't water the garden that morning.
Don't water that. Very frugal as far as water-wise. But again, thinking about how to prepare for the future. 50% may be interpreted widely by people. Does it mean that 50% of San Francisco will be rained upon? Does it mean that somewhere in San Francisco there's a 50-50 chance it's going to rain? If it rains in part of San Francisco, it won't rain anywhere? Does it mean that on 50% chance, days like that day, it will rain? Or does it mean, these apps, they don't mean it, nobody knows. I'm just going to go with my almanac. So there's the interpretation phenomenon. It's the same thing that happens in healthcare. What percent, if you take a bunch of ICU patients and ask their family members some questions, what percent solely rely on the physician's estimate when determining prognosis? Raise your hand if you think it's 90. Raise your hand if you think it's 80, 70, 50, 40, 30, 20, 10, 5, 2, 2%. So this should relieve some of the burden we feel as healthcare providers that what we say is going to have a monumental effect on our patients. It has an effect. People actually do rely on your estimates. It's just not the only thing that they use to estimate their own prognosis or their loved one's prognosis. They use other things, like their knowledge of the intrinsic qualities and will to live of the patient. What's the word that people say?
Fighter.
He's a fighter. He's a fighter. Where did they come up with that? I have no idea where people came up with this terminology that there's a fighter, but we hear it often. Other things that they used, observations of the patient. That monitor, the numbers are getting lower and lower in the blood pressure. That's great. He's had high blood pressure all the time. He's going to do great now. So they may be interpreting information correctly or wrongly. History of survival of illness. He beat prostate cancer. He's going to beat this metastatic lung cancer. Surrogate's belief in the power of the support and presence. If I just sit here and be here all the time, he's going to do better. Optimism, intuition, and faith. And for about 20-30% of the time, faith overrode everything else in prognostic estimates. Are we asking about how spirituality and religion affects how people think about prognosis and making these decisions? Because odds are it's probably having some effect. And for nearly a third, it's going to be the primary effect in determining prognosis. And the other thing, this again comes from Doug White, who used to be here at UCSF. Surrogate decision makers' interpretation of prognostic judgment. So, for example, and these were asked of family members of patients in the ICU, if a doctor says he will definitely survive, what does that mean to you? If you had to if somebody said that to you, he will definitely survive, and over here, it's will not survive, 0% chance, under 0%. And here, 100%, he will survive. Where would you put this checkbox? Here? What about he will definitely not survive? 50%? Where would you put it? So, if you look at people, these surrogates, you can see that he will definitely survive. Most people say, oh yeah, going to survive. The more pessimistic the prognostication became, the more variable it was, and it tended towards optimism. So he will definitely not survive. Maybe 0, but maybe it's 50% chance that they're going to survive. If they're told he will definitely not survive. And when asked why did people do this, people couldn't really explain it. They didn't really know sometimes why or that they did it. But there is this tend towards optimism. We're optimistic when we formulate prognosis. We're optimistic when we communicate prognosis. Surrogates are optimistic when they even hear the prognosis. And this comes down to the last thing that we should be doing when we're talking about prognosis with patients is don't just stop in communicating it. Ask people. Ask if it's changed all what they told you in the initial ask. So when you ask them, what do you expect will happen in the future? Did what I just tell you change that at all? Given this information and what you've told you about how long I think you have to live, what do you think about your father's prognosis? And that appreciation of this discussion is really important because we know that people interpret prognostic information. Even if I showed a 50% chance that it's going to rain on Wednesday, you're still going to interpret that information. You may think, oh, it's weather.com, and this is pulled from weather.com. You know what weather.com does? There's a wet bias. Anybody heard of wet bias before? So they know you're going to get mad if they say it's not going to rain, but it rains. So they change their probabilistic estimates higher. So, because they know you're not going to remember that it didn't rain when they said it was going to rain. Like, you're not going to remember that on Wednesday, but if it actually on Tuesday when they say it's not going to rain and it rains, you're going to say, weather.com, that's terrible. I'm going to go to AccuWeather instead. So they have a bias just like we have a bias. So these are the 3 parts. Key 3 parts. Don't forget them. When you're thinking about prognosis, each one of them is very important. And we're just going to end with questions. Questions? Yes, in the back. Microphone so Davies can hear.
Hi, thank you very much. This is really helpful to me. I'm not a medical person. I'm a lay person serving on hospital ethics committee and very interested in this, and a business person. One of the things that I think the medical profession, to be broadly stereotypic, leaves out of these conversations is how much all this stuff costs. And over 60% of the individual personal bankruptcies are caused by medical-only expenses. And I get that that's a heavy ask, but somehow as a country, we have to figure out how to do things differently because in my own case, if I've lived a good life, irrespective of whatever, and I'm peaceful with that and I have my marbles, and I'd rather have my children have the money than Big Pharma or the surgeons or whatever, that's a very legitimate decision criteria that if I don't know X is going to cost $2 and Y is going to cost $10, to be simplistic, then I can't make that decision. And we haven't gotten there as an industry yet, but we need to get there.
And I just want to, this is part of also like what Shoshana is doing and Ken is doing, everybody's doing here with what kind of these key principles in palliative care, because it turns out if you ask people about what's important to them, what their preferences are for certain decisions, whether it be end-of-life decisions, surgeries, or other things, it may not always be the default in medicine, which is do everything to everyone as long as possible, no matter what the cost. And if you actually ask people and talk to people about these things, you actually do, and we have multiple studies now that it actually affects total cost of care, which decreases. And this is kind of why we've seen a tremendous growth in palliative care in hospitals, because hospitals realize that palliative care consults save money by asking people about what's important to them, that it may not always be keep me in the ICU for as long as possible. which I think for healthcare providers may have been an initial shock that sometimes we're not doing the things that people want us to do. Other questions? Got about 2 more minutes.
Yeah, my question was around the tendency of physicians to maybe extend the estimates of how long patients are going to live. And I guess setting aside like the ethical implications of that, is there data that giving people hope leads to better outcomes, either emotionally or overall? Has anyone studied that?
So there's been studies looking at end-of-life discussions and whether or not they do, which often involve prognostic estimates. And there's no signal that they increase anxiety, worsen depression, or have any other negative effects on patients. And I think the funny thing with hope is, I think this is, when we talk about prognosis with patients, we often think we may be taking away someone's hope by delivering a prognosis. But in truth, people have multiple hopes. It's not just, again, will I survive another year? Will I be able to be with my family? What are some other options? People also want truth. Not everybody, though, actually wants to hear the bad information. Some people do feel like it may take away their hope. And for those people, take a step back. Focus on some other aspect. Like, we don't have to, again, push. And I've seen this multiple times where even I'll try to push this on people, like, you have to understand, but they're not ready. And if I just try to push, they're going to be not ready for longer. And the other, what was I going to say? One other important aspect around hope. I'm blanking on it. But did that kind of answer your question?
Yep, absolutely.
Yeah. And the other thing I was going to say is, sometimes the fascinating thing is, like, we may tell somebody that we're thinking it may be months, it may be shorter, it may be longer, and they think, oh my gosh, I didn't know it was going to be that long. And it's amazing that people actually have their own prognostic estimates, and often it's shorter than what you think. Yeah.
There was a study done a couple of years ago by Dave Feldman, who's down at the University of Santa Clara, where he was looking at hope for people in hospice with a malignancy. And 30% of the people who were no longer receiving active therapies thought that they would be cured of their disease. They're in hospice. So it's actually pretty difficult for many people to take away hope.
Yeah.
There's something about hope springs eternal.
And I think people can actually hold dichotomous hopes. And we've seen this a lot of times in our hospice unit. People who we think may have days to live, and they're still hoping for a cure, but they realize it's probably not going to happen. And they actually realize it may be an unrealistic hope. And my job is not to take that away, but to hold on to that with them. And this is kind of the I wish statement, or the I hope too. Like it does, like if somebody is hoping for a cure and I know they have metastatic colon cancer or lung cancer, I can hope for their cure too. And I can also think about what if things don't go the way we hope. And we use that line often. Yes?
I'm just wondering if in one of your last slides where you were dealing with the last thing, like what did they really hear?
Yeah.
You used the word prognosis in your model sentence, and as another civilian, I'd like to say that I think people are so bewildered and overcome and having trouble thinking about anything when they're getting this kind of bad news that having to learn a new vocabulary word like even prognosis is really, really difficult. It just adds to the level of trying to seem smart enough and trying to digest things. And yet it's hard to think of what are really good analogies. I mean, do you have like a set of other words like forecast, our best guess?
What do you expect will happen in the future?
Yeah.
I use the expectation. Honestly, though, and I think this is the important part, is I use terrible jargon all the time. I use prognosis. I use these big words that only somebody trained in medicine. I think the one thing that I try to do is actually have social workers, other people in these meetings, so when I do say something that nobody else should reasonably understand what I'm saying, is they stop me and they say, oh, Eric, you said you mentioned prognosis. Can you describe what that is to me? And they're really good. My team is really good in bringing that up. And I need that because I'm so indoctrinated in the medicine culture that I'll just jab away talking about things that nobody else understands. But I like to expect. What do you expect in the future? What am I expecting in the future? It's just the way to think about prognosis. Even things like likelihood is not something that.
It's almost like it's become a euphemism for, have I made it clear to you that your life is limited? You know, I mean, the way.
Yeah, there's a Seinfeld episode on prognosis negative. I think that. Maybe we'll end, or. Well, I'll actually take any questions here. I want to be respectful of anybody's time, but thank you for joining me today.